Hello everyone, my name is Johnette Harlan and my presentation is on sexual dysfunction. Well, what is it? Sexual dysfunction is the inability for a person to enjoy sexual encounters. The person may experience repeated difficulty with sexual response, desire, or orgasm, or pain. Risk factors. I do want to note that this list is plentiful. I'm pretty sure everyone can think of a risk factor that can be joining this group. I feel like it's endless, but the ones that I have listed, just to name a few: hormonal imbalances, STIs, painful sex, urinary symptoms, age. It kind of can go on and on. Epidemiology. Oh, wow, say that 5 times fast. But I do want to say a lot of the articles that I read list questionnaires in the DSM-5. This is how you would essentially would start a diagnosis for this sexual dysfunction. And a few of the key points I would like to point out: 40% of women worldwide report sexual complications. The peak age group is between 51 and 59. It is generally highest in Southeast Asia and lowest in Northern Europe. Subjective findings: vaginal dryness, vaginal pain, emotional distress, difficulty becoming or staying aroused, difficulty or inability to achieve an orgasm, or painful sex. Once again, I'm sorry. Objective findings are the hormone imbalances, it could be vaginal odor or discharge, a prolapse, the rectal seal, the vaginal seal, that can cause pelvic pain. Withdrawn to any form of touch, no or lack of eye contact, or inconsistent story of events. I definitely don't want to say lying, but when you talk to patients who have been through some form of abuse, a lot of their stories are inconsistent. They do lack eye contact. They're kind of looking at the wall. Primarily, they're always looking down. And anytime, you're trying to do their exam, they're definitely jumping. They're very jittery. And I feel like this picture represents what I was just saying. This patient right here looks very withdrawn and concerned. Like, oh my gosh, she's touching me. So the workup. So what do we do? Of course, we want to know about their medical, sexual, and social history. Do they drink alcohol every day? Do they have a history of drug abuse, sexual abuse, diabetes, hypertension, all of which could play a part into some form of sexual dysfunction? You want to evaluate the safety risks at home. Are they at risk for domestic partner violence, medical reconciliation? You want to review their medications, physical, pelvic exam, lab work. Of course, that is not all the lab work that you would do, but that kind of give you an idea where you want to start from. Pretty much like a hormone panel. PAP, the good old PAP with HPV, can never go wrong with that. The STI panel, the urinalysis, urine culture, transvaginal or pelvic ultrasound. So this will get the ball rolling. The diagnosis: female orgasmic dysfunction, arousal disorder, penetration disorder, female sexual interest disorder. I do want to say that was the most common in all the articles that I read. Female sexual interest disorder. Your patient just had that lack of desire, and it coincides with the age group that it's most common with, which is 51 to 59, the menopausal, postmenopausal age group. So our little stressed out doctor here, she looks very worried and very concerned, doesn't she? So, hey, that's odd. So, what could be an odd finding? So I do want to note that I was kind of pulling at straws here. I really did not find much information, so I kind of had to go rogue and do my own thing for this part. Hope it's not wrong. But Asexual religious beliefs, isolation, fetish disorder, necrophilia, abnormal genitalia anatomy. Asexual, you have people out there who have absolutely no desire to have sex with anybody, man, women, transgender, absolutely nobody. And then you have religious beliefs. A lot of religions uh, have their people believing that sex is only good for producing, not for enjoyment. So unless you're planning to produce, you shouldn't be having sex, which can form some level of sexual dysfunction. Isolation, that really goes for people who have been abused and they like, screw it, I don't want to deal with nobody. Then you have fetish disorder, people who find inanimate objects with for sexual desire. Then necrophilia is for people who have sexual desires for dead bodies. Abnormal genitalia anatomy, that goes beneath the category of, unfortunately, a lot of women went through circumcisions where their clitoris was cut off or part of it was cut off. And when you do their exam, you notice like their anatomy is very different. It's not the normal. So that's odd. And that is, all those are pretty odd. All right, so moving on. Plan of care. So you obviously, the first and foremost, you want to diagnose and treat the underlying issue. Maybe something, a quick fix as far as, a medication adjustment, going from Zoloft to Wellbutrin. Who knows? You want to eliminate or adjust the medications, refer the patient to a sex therapist, psychologist, education on sex practice, safe sex practices. You want to promote masturbation. A lot of times women don't know what gets them off, essentially. Maybe it's more so clitoral stimulation versus penetration. You want to promote new, healthy, safe sexual ideas and encounters. Obviously, you don't want your person just, released out into the wilderness, having sex with everybody unprotected. You want to make sure that they're safe, it's consensual, and they have a trusting partner or partners before they just decide to explore new ideas. So medications. So you have your estrogen therapy, you have your Addy, which is the quote unquote female Viagra. You have all of these things that you can help promote a nice, healthy sexual lifestyle for your patient. I do have my disclaimer. Please make sure your patient is medically cleared to take these medications that are listed, because as we learned in our previous weeks that, with estrogen, can't have a cardiovascular history, or, you make sure you have a uterus before you use that. So, same thing with Addy. No cardiovascular history with that. All right, so moving on. So this is a table that I put from this article listed. I'm not going to butcher the name. But I did find this article very helpful. It was actually my favorite article was doing this research. These are the tables that I pulled from it that I plan to put in my pocket guide that I think you guys should too. But obviously, you can review the article and do your own thing. But I just really found these helpful as far as the questions, the DSM-5 criteria. I just found it beneficial to have in the back pocket. So that's why I put it here so you guys can pull from it too. And these are my references. Like I said, this was probably my favorite. And thank you guys for listening to my recording. Hope you enjoyed yourselves. You guys have a great day. Thank you.